As the lymphoma expert, I may only see some of these diseases once or twice or three times a year. So if you were a community doctor, you probably never see patients with these diseases.
In this episode, Cancer Network spoke with Dr. Neha Mehta-Shah from the Washington University Medical School in St. Louis, Missouri, who outlined the clinical landscape for patients undergoing treatment for rare lymphomas. Specifically, she touched upon developments in treating patients with these rare diseases, including advancements in diagnostics and the emergence of genomic testing for the development of targeted therapies, as well as challenges to treatment and ongoing clinical trials that appear promising for these patients.
There have been many advances in the treatment of rare lymphomas. I think one big category of those is in diagnosis. I think there have been advances in the ability to use things like mutational profiling or genetic sequencing of cancer cells that has helped to refine the diagnosis of many rare diseases. Some of these diseases have a specific genomic hallmark that now helps us to define or identify these diseases and improve our diagnostic capability. Some of the other advances have been certainly in the development of newer therapies. So once we kind of know how to better define these diseases, we've been able to understand the biology quite a bit better, and that's led to the development of both IV and oral therapies for cancer. Some of these include things like immunotherapy, as well as targeted oral inhibitors. One example of how both the diagnosis and the treatment of rare diseases has improved significantly, even in the course of my short career, has been in the world of rare T-cell lymphomas. So we know that we used to have a grab bag term of patients who had peripheral T-cell lymphoma not otherwise specified, and that used to be the majority of systemic or peripheral T-cell diagnoses. But over time, our ability to refine which patients had T follicular helper phenotype lymphomas, of which the prototype is angioimmunoblastic T-cell lymphoma, has improved significantly. That's been through better diagnostic criteria that include staining for things like ICOS and PD1 and CXCL13. But in addition, then now the genomic testing has really improved our ability to help confirm these diagnoses. Many of these diseases have recurrent mutations in epigenetic modifying genes like TET2 or ROA or IDH2. And then putting all those pieces together has helped to better refine the diagnosis of the disease. That also led researchers, including myself, to start looking at drugs that specifically work on the axis of the epigenome to see if they have better efficacy in diseases like AITL or T follicular helper phenotype lymphomas. And one of the things that we found is that drugs like romidepsin, a histone deacetylase inhibitor, does have higher response rates in patients who have T follicular helper phenotype lymphomas. This has also led to further studies using PI3 kinase inhibitors that also seem to have preferential activity. Sometimes we think potentially through affecting the microenvironment even, and also with drugs like EZH2 inhibitors that also affect the epigenome seem to have selective activity in AITL. I think that's just one example. If you take some of the other very rare lymphoproliferative disorders, like things like Erdheim-Chester's disease, which has recurrent aberrancies in BRAF, the discovery that patients have higher expression of BRAF and mutations in BRAF led to the use of drugs that were developed for BRAF mutant melanoma to be then translated to very rare diseases like Erdheim-Chester's, leading to very long remissions in therapy, on therapy. And so I think in these rare diseases, doing some understanding the biology had been a major impediment to the development of therapy. And as we've learned more about these diseases through really collaboration nationally and internationally, that has then led to translating things that we knew from other diseases to rare diseases, and then specifically developing therapies for these rare diseases. Another area where I think in rare diseases that will be and has already shown to be significantly important is the use of dynamic personalized medicine monitoring. What I mean by that are things like not only using mutational profiles or baseline characteristics of the tumor, but also profiling how the disease responds to therapy by using things like minimal residual disease. In treating lymphomas, almost all lymphomas by the definition of rare diseases by the NIH are all rare diseases, actually, because there's the incidence of lymphoma specifically is in the order of 80,000 cases per year. And that encompasses like over 100 different diseases. Pretty much every lymphoma is a rare lymphoma. Even the most common lymphomas like diffuse large B-cell lymphoma occur at a rate of about 5.5 per 100,000, which make that a rare disease too. So then there are like even rarer diseases, like very rare subtypes of lymphoma as well. So if you in that realm, the use of MRD-directed therapy in diffuse large B-cell lymphoma, I think, is going to become very relevant. There are already tools to look at things like cell-free DNA at the end of treatment in diffuse large B-cell lymphoma that have been approved, and trials using dynamic monitoring using cell-free DNA to decide to evaluate whether escalation of therapy to either like other chemotherapy or stem cell transplants or bispecific antibodies or CAR T cells is warranted for people who have were MRD positive at the end of treatment or have insufficient decline in their cell-free DNA. So I think in that world, there will also be a big shift, and that shift is already being translated into ongoing clinical trials. There are lots of issues that make it harder to treat patients who have rare lymphomas, and then there are additional issues with rare lymphoma research. Rare lymphomas that are amongst the particularly rare. Now we're talking about lymphomas that make up 2 to 4 or 5% of all lymphomas. Often are understudied, as we were talking about earlier, that some of these are diseases for which the diagnosis is particularly challenging. It's challenging for pathologists to make the diagnosis. It often takes a longer time to make the diagnosis because the local pathologists who may never have seen this disease before usually have to send the biopsies off to an expert laboratory, academic medical center, or a reference laboratory, and that can often take weeks to make the diagnosis, which can be really hard for both doctors and patients, particularly if patients are symptomatic. And then when we look at like how much information there is to guide our options for therapy, there's often a paucity of prospective, well-vetted data to help guide therapy. So in other diseases like treating breast cancer or lung cancer, we're fortunate to have these very large studies where half the patients got treatment X and half the patients got treatment X plus Y. And you can really inform patients about what their choice is and the risks of adding Y to X, as well as the benefit of adding Y to X. Whereas in rare diseases and rare lymphomas, sometimes the whole study to help inform a patient's therapy could have been 20 patients or 15 patients or 30 patients. All of those patients got the same therapy. It wasn't directly compared to any other therapy. And sometimes you're extrapolating information from related diseases to their disease. And so it can be really hard to take care of these patients because it really requires kind of digesting the information that's available and sometimes relying on expert consensus guidelines to help guide your decision making. Sometimes we have these rare lymphomas, and that are in order to like just better understand them and categorize them, are put together in one category, but they usually encompass more than one type of disease. So marginal zone lymphoma is a perfect example of that, where patients can have marginal zone lymphoma, but there's really multiple subtypes of marginal zone lymphoma. Patients who have primary cutaneous marginal zone lymphoma, patients who have splenic marginal zone lymphoma, or nodal marginal zone lymphoma, or mucosa-associated marginal zone lymphoma. And these are fundamentally different diseases. They have different biologic drivers. They have different propensity propensity to affect different areas of the body, and we treat these differently. And because marginal zone lymphomas are rare, most studies in marginal zone lymphoma encompass all these subtypes, but helping a patient understand how a particular drug or particular therapy is going to work for them relies on us to then look at that data specific to that patient and do kind of a subgroup analysis. And there's usually those numbers get really small in helping to understand the likelihood of response or the duration of response for a particular patient. And so I think while we don't rely on retrospective studies in all areas of medicine to inform our practice, in rare diseases, sometimes retrospective studies are the best information we have, or real world registry type of studies, maybe the best type of information we have to help guide our clinical decision making or inform development of national guidelines. There are many agents currently being studied that are promising in rare lymphomas. I'll kind of break down into certain categories. So one group of studies are the studies in T-cell lymphoma, which is an area I'm particularly passionate about. And we've been very excited about the development of both PI3 kinase inhibitors and EZH2 inhibitors in T-cell lymphomas because the studies now consistently across multiple drugs in the same class for both types seem to show that these are drugs that are efficacious even when chemotherapy or other standard agents have not been efficacious for these patients. And these patients have particularly few options for standard treatment nationally and internationally. So that's one group of therapy that we're really excited about for rare diseases. In things like cutaneous T-cell lymphoma, there are some studies exploring those classes of medicines, which are exciting. But then in addition, there have been studies looking at novel antibodies, and particularly antibodies against KIR-DL2, which have shown very durable remissions with improved quality of life for these patients who really suffer from a high impairment in their quality of life when due to both their disease and in some situations due to their treatment. And we're excited about this novel class of medicines in that arena. The other area that I'll say that we're really excited about is the use of immunotherapy in Hodgkin lymphoma, which is also a rare, very rare lymphoma, but a significant number of people with Hodgkin's are young adults. And as we've gotten better at treating these patients and curing some of these patients, we're really trying to develop treatments that have less side effects long term and don't increase their risk of other healthcare events like heart attacks, strokes, breast cancer, or other cancers. And with the development of immunotherapy earlier in the course of therapy, which was a large U.S. intergroup effort to demonstrate that nivolumab AVD may be beneficial, at least with a progression-free survival benefit over brentuximab AVD. That's very exciting. And I think how to now de-escalate that therapy and potentially give less chemotherapy or monitor quality of life to decrease long-term side effects is one of the goals. There's currently a U.S. intergroup study looking at patients who have early-stage Hodgkin lymphoma, incorporating brentuximab and nivolumab earlier in their course of therapy. Similarly, that also is measuring survival, survivorship, as well as quality of life. And I think all of those things are very exciting for our rare lymphoma patients. Yeah, there are many unmet needs for rare lymphomas. I think just the term rare lymphomas probably encompasses like 40 to 60 different diseases, and each of them have like a specific unmet need. Some of the needs that we need to address are things about the rare lymphomas that we can cure. So things like primary mediastinal B-cell lymphoma, gray zone lymphoma, Hodgkin lymphoma, diffuse large B-cell lymphoma. These are all lymphomas where the purpose of the treatment treatment is to cure them. And but we know our current therapies don't cure 100% of patients. So there's room for improvement there across the spectrum, but also room to improve with regards to minimizing long-term toxicity, minimizing late-term effects of chemotherapy, and to monitor quality of life and better understand the patient experience through patient-reported outcomes remains an area of unmet need. And there's lots of work being done nationally to do that, lots of efforts to look at survivorship, rates of fertility, impacts of neuropathy, and really measure these systematically using novel patient-reported outcomes tools that are being developed specific to these diseases to better understand the outcomes of therapy. Some of this is being done by the LEO Consortium, the Lymphoma Epidemiology and Outcomes Consortium, which is a national consortium to kind of better understand the impact on quality of life, financially, socially, emotionally, of having a lymphoma diagnosis on those respective components. There are other rare lymphomas where there really isn't great therapy for. The median survival for patients who have relapsed refractory T-cell lymphomas is only 6 to 10 months. So there's a lot of room to improve on treatments for patients. And in the current era, the FDA has really pushed for randomized phase 3 studies to lead to approval, which has led to actually the withdrawal of drugs like romidepsin's label in T-cell lymphoma, making it even more challenging to pursue phase 3 clinical trials in this space. Because there's really not a great comparator, so it's hard to design studies that patients and doctors want to be involved in, where patients could be randomized to treatment that is not super likely to be effective, although that is the current standard treatment. And so I think the regulatory impacts, which we very much understand why the FDA chose to make these decisions, do have downstream effects on the ability to develop clinical trials for patients with these rare diseases. I think will continue to be a continued collaboration between the FDA, industry, clinical investigators, and patients to kind of bring these promising drugs to patients in local areas and not just at academic centers through clinical trials. And then there's a huge area of dissemination of information that's important in rare diseases. Even at large academic medical centers, sometimes for even for some of these ultra rare diseases, as the lymphoma expert, I may only see some of these diseases once or twice or 3 times a year. So if you were a community doctor, you probably never see patients with these diseases. And it's only becomes relevant to you when the patient is sitting in your office or in the hospital with you, and how to help best educate providers about what therapies have been developed and what information is emerging and how to get the best treatment for your patient, and make that available to every patient is a huge area of unmet need. As we kind of have now developed bispecific antibodies for lymphoma, which have become a big part of clinical practice for diseases like follicular lymphoma and diffuse large B-cell lymphoma, one of the challenges we now face is how to make those therapies easily available in the community and help doctors in more rural areas or for patients who are far from large academic medical centers. How do we give them access to those therapies in a way that's also safe and make sure that other providers feel comfortable giving those drugs and monitoring for the unique toxicities of those therapies? So that, I think, is a huge area of unmet need that's continued as well. That certainly applies to curative therapies like CAR T cells, where there are significant barriers to patients receiving that sort of care. I think there are lots of ways that we hope to improve on the barriers to care for patients. I think in terms of making the diagnosis, I think there are many ways that we think that AI or other tools may change our lives. But in one of those areas may be in assisting in making diagnosis of rare diseases, maybe something that tools like AI can help pathologists with kind of coming to the diagnosis or integrating information about different molecular and pathologic features. So I think that's one area that will be coming in the future. We're certainly not there yet and don't know how to best utilize the tools that are currently being developed, but that is an area of ongoing investigation to improve on those barriers. I think another area that will be very important in improving on the barriers will be figuring out how to develop off-the-shelf CAR T-cell products or CAR T-cell products that have minimal manufacturing time. Right now, for patients who have who are looking towards receiving CAR T-cell therapy, usually are getting, need an insurance approval, that before that they need certain types of testing. And then once they have insurance approval, then they can do the collection. And then there's a period of many weeks of manufacturing before the actual CAR T-cell product gets to the patient. And so improving that, apheresis to vein time, or I would say from thought to vein time really is really critical. And there are many, many barriers that patients and doctors face in getting the therapy to patients, even though we know it's potentially life-saving. And those are certainly areas for rooms for improvement at multiple levels, probably at the level of payers, at the level of making those therapies more available in more places other than larger medical centers, and then also improving the production time. Off-the-shelf products may be able to overcome some of those barriers because they won't require a production time as well. And then I think, there are the ability to develop oral therapies is also, I think, going to decrease the barriers. Many therapies that require frequent infusions are impractical for patients, and especially patients who are farther from the medical center or who are trying to, live their lives and work or take care of their kids or take care of their elderly parents. Some of those therapies are not feasible for our patients. And so the development of oral therapies or therapies that patients can do at home will really, I think, revolutionize the ability to take care of some of these patients. We know some of those are hopefully coming for us in T-cell lymphoma, similarly to how they've changed the world in CLL and mantle cell lymphoma. And so I think there are, and then I think the last part is the issue of cost of care, but that's a much bigger problem to fix. And especially the cost of oral therapies has become sometimes prohibitive. And we're really grateful to nonprofit organizations that have really tried to help patients through supplemental grants like the LLS or to industry partners in providing patient assistance programs, but it still hasn't solved the whole issue. Because rare lymphomas are rare, less people are affected with one given disease and less providers are seeing a lot of patients with this disease. And so sometimes they're an afterthought. And in the current era of probably more decreased funding for scientific research, I think it's really important to continue to advocate for rare diseases and improving treatment for these patients. I think it has always required a group effort on the parts of patients, advocates, scientists, clinicians, and clinical researchers in helping patients with these rare diseases, but that teamwork is going to become more essential in the current era.